Hey everyone at home, this is Dr. A. We're going to go over Chapter 2, Current Operations of the U.S. Healthcare System. And our main objectives are going to be looking at the stakeholders and looking at statistics and comparing with other countries. Okay, so did you know, according to the Bureau of Labor Statistics, there's a big projected job growth in healthcare over the 10-year period, and it's 9.8 million jobs by 2024. So that statistics obviously was from a few years back, but kind of the lesson there is there's pretty much always jobs in healthcare. And sometimes if you're not finding exactly the one you want, a lot of times maybe just relocating to a different area because there are needs all over the country in healthcare. Most healthcare workers have jobs that do not require a 4-year college degree. A lot of them some of them can require, it's not even a college degree, it's like a certificate. That's like the 1-year training, like the LPNs. And there are others that might be even just 6 months training. And then there are some that are associate's level, and then some that are bachelor's level, and then we go on up in them. So most health diagnostics and treatment providers are the most educated workers in the United States. So for example, for like if you go in radiology or lab sciences and stuff like that, clinical lab sciences, you have to have pretty much a bachelor's. Although in lab science we do have an associate's, and there's still some associates of radiology here and there, just not here at A-State. It's a 4-year degree. But the treatment providers, like your doctors and your nurses and all that, obviously are well educated, and a lot of them have at least a 4-year degree. Doctors having a doctorate, of course. The healthcare industry and social assistance industry have more work-related injuries than any other private industry. So this is obviously excluding the military, which would be public. The life expectancy and infant mortality rates are a couple of the stats that are indicators of the health of the population, and some of those we'll look at. So here's a quick poll. What type of injury do you think is the most common in healthcare workers? So just give it a guess, and I'll share the results of this survey later. Okay, let's talk about stakeholders. So a principle of the U.S. healthcare system is the duty to treat. So any person deserves basic healthcare. And that's, we mentioned last week, the EMTALA, where you should be able to go to an ER and get some care, even if you don't have a provider, even if you don't have money and all that. So that's part of our duty to treat. So in the U.S., in order to provide healthcare services, there are several stakeholders. Think of them as players in the system, players in this game of healthcare. And or here as they define them, interested entities that participate in the industry that healthcare is. From an organizational perspective, of course, the consumer is the most important stakeholder of an organization, because if you don't have a patient, then you have nobody to take care of, you have nobody to run tests on, you have nobody to diagnose, treat, prescribe to, and stuff like that. So the patient is definitely the cornerstone. Okay, so who are all the players in the game of healthcare? The patients obviously are the main group of consumers, and they include those who need healthcare services from physicians, hospital, outpatients, facilities. So being the consumers, they're the main driver of the industry of healthcare. All right, and then of course you have the employers. So the employers include both private and public employers. So private employers would be like some of our local hospitals, they're private employers. Public employers would be like if you want to go across the river and work for the VA hospital, you'd be working for a public employer. And the healthcare industry is the largest U.S. employer as a whole. And certainly in this area, there are also some of the largest employers in the area. All right, then you have hospitals, nursing and residential care facilities. So nursing residential care, those are can be usually long-term care. It's really what we talk about when we refer to nursing and residential care facilities. But sometimes some people will just go there for a short stay and then go on home. Your physicians and other healthcare practitioners, so that would be your PAs, physicians assistants, nurse practitioners, and all that. So those that, assess patients and devise treatment plans and all of that. We have home healthcare services. So these are people that go out to people's homes. For example, I know respiratory therapists can do home healthcare, and they can go and set up oxygen and check on different things and maybe sometimes refill some of the tanks, etc. And then you also have people, you have nurses that can give care at home, become having IV drugs and stuff like that. And of course, you've got the health services where they're just you have a sitter or somebody that's given some cleaning services and stuff like that. So those are all kind of tied into home healthcare services. Outpatient care centers and ambulatory healthcare services. So those are any place that where you would go. Well, outpatient care would be clinics, but also like one-day surgeries where you go have a minor procedure done and you don't stay, you go home. Ambulatory, to ambulate means to walk, so any kind of walk-in type clinics and stuff, so where you would go for your appointment and leave. So your urgent cares would fall under those, but also just your doctor's offices and stuff. And quick little poll again here. I will share the answers later. So who do you think has the largest medical staff in our region? So we have choice between Arkansas Methodist Medical Center, NEA Baptist, and St. Bernard's Medical Center. So who do you think has the largest medical staff? All right, so more of the stakeholders, more of the players. We have all the laboratories. So the laboratories provide diagnostic services. One of the things we've been able to more or less quantify is the doctors, the medical decisions for treatment and all that are mostly based on laboratory and, of course, imaging type of tests. So we say about 70% of healthcare decisions made by the doctor are based on laboratory results. So really important. And so within laboratory, I would also attach to that, have listed all your imaging, radiology, and all of that. Your third-party payers, so those are entities like the government, so think Medicaid, Medicare type things that pay for services, and of course insurance companies, they're private usually, and individuals paying, because you can pay out of pocket for services too. And you also usually have like co-pays and stuff like that where you're paying into the system. And then we have educational and training organizations such as A-State and other schools that train up the workforce, of the future. So we've got to keep replenishing that workforce. So those are important too. Because if you don't have them, then you don't have people to staff the hospitals and stuff. Research organizations. So a lot of the universities are also research organizations, but things like the NIH is a research organization too, that's governmental. And of course, doing research drives the progress of the healthcare industry. Professional associations, so those are usually specific to different professions. So for example, I'm a lab scientist, we have the American Society for Clinical Lab Sciences, and some of the stuff that they do. The two main things is continuing education for the workforce and stuff, and then the other thing is lobbying to the government, to Congress on Capitol Hill, to make sure that some of the policies and stuff that they pass are actually good for patients and good for the lab industry, and it's not going to create problems down the road. Pharmaceutical companies, of course, doing drugs, making all the drugs and stuff like that, and discovering new drugs and getting them out to the market. So there we go. I've got as our activity, we got a matchup. So the way you do these is you click on one, like laboratories, and then go find the meaning or the definition, like the type of service that it provides, and click it. And if it's correct, if it's incorrect, it turns the red, and if it's correct, it's going to turn green. So laboratories actually do that. Okay, and yours may shuffle and maybe in a different location there. Okay, so let's talk a little bit about statistics. So statistics are calculated to assess healthcare services in the U.S. because if you don't measure, then you don't know really what's going on. The National Center for Health Statistics is based out of the CDC, and it produces an annual report on the health of the nation. Life expectancy rates are calculated to assess the health of the nation, and infant mortality rates are also calculated to assess the health of the nation. And there's been a trend in life expectancy rates that for the longest have been going up. So before the last like 100 years or so, the some of the life expectancy a few hundred years ago was like 40, 50. It was really low. And then with public health and healthcare and also modernization of the food supply and all of that, it started going up, 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 up. And then what we've been having, so with a lot of processed packaged food, sodas, so much sugar and junk in our food system, is now we've gone up and now we're going back down. So life expectancy is actually going down. So basically what it means is, well, our young people today are not going to live as long as their parents would have or are going to live. So it's been kind of sobering to see that, and a lot of it has to do with lifestyle. Okay. So healthcare has a direct correlation with having healthcare insurance. So obviously if you have insurance, then you're more likely to use the healthcare services and to seek help for problems. Uninsured and underinsured statistics are calculated to assess healthcare, access to healthcare. So how many people we have in the US that are either underinsured, that means they don't have enough coverage, which kind of impedes their usage, or they're not insured at all. So if you have let's say like I'm having a little bit of congestion, allergy symptoms, if you have access to healthcare and you feel like you need to go see a physician and you have health insurance, then you'll go to urgent care, or you'll go make an appointment, go see a physician. If you don't have that, you're like, well, the only way I can get any kind of healthcare is to the ER. ER is not really going to take care of this. You just don't. You just let it go. So we're going to look at a few activities with life expectancy and stuff. So this first one, what I want you to do is I want you to click on this right here. It's going to pull up the table. So do that when your activity, and then answer according to this 2017 life expectancy table. Here, it's not distributed, I'll just put it there. Who has the shortest life expectancy at birth? And you're going to see these tables, you're going to see at age 0 how long you're expected to live, and it's broken down here in white, white, black, Hispanic, and then we've got man total, but then men and female and stuff like that. You can go. So at 0, this is at birth, but then like you say, the last line is at 100. So if you can reach 100, how many more years would you have to live? So that's how the life expectancy table works. So we've mentioned this already a little bit in the orientation. The Organization for Economic Cooperation and Development, or OECD, they monitor trends of economic development, but also healthcare coverage and stuff. Currently, there are 35 countries, including the United States, and 9 partner countries that are members of this organization. All right, so health indicators such as infant mortality rates, average life expectancy, and health risk behaviors are used to evaluate the health status of a population. So health risk behaviors will be things like how many people drink alcohol, how many people smoke tobacco, how many people are overweight or obese, etc. Okay, so let's talk a little bit about the gross domestic product, because that is one of the measures that they look at with looking at how much we spend on healthcare. So it's the gross domestic product is the percentage of products or services produced within a country's border. So it's actually the total, you can calculate it. They put a percentage there, but you actually can calculate in millions or billions of services provided or goods produced and stuff like that. And then you can look at that and see how much is spent on healthcare, how much is spent on IT, and all that kind of stuff. And so we spent a big chunk of our GDP on healthcare, which is the highest percentage of the 35 OECD members. If we spend the most, shouldn't our statistics be the best? And as you will see, they are not. Okay, so let's look at the 2015, so this is 5 years ago, OECD statistical highlights with looking at life expectancy. And so for all the OECD countries, life expectancy on average is 80 years, 80.6. Japan, Spain, and Switzerland have the highest life expectancy rates of 83.9 years, 83 years, and 82.9 years. So about 83, 84 years respectively. And when we look at international healthcare systems later on, you'll see Japan, Spain, and Japan and Switzerland for sure, but even Spain have really good healthcare systems. Switzerland has got one of the best ones, and Japan they've got it figured out. It's really good. The lowest is South Africa at 57.4 years. The U.S. average is 78.8 years, so we're a couple years behind the average for OECD, and we're more like 4 to 5 years behind some of the better countries. So why aren't we first? Why aren't we in this list here with Japan, Spain, and Switzerland? Okay, so life expectancy rates are a measurement of mortality for a designated age group in a particular year. Gender does have an impact on life expectancy. So life expectancy is usually calculated at birth by ethnicity, age, and age 65 and gender. So at age 65, if you look at the table that you have to go to look at it again, so you can see there will be numbers there. That means that's how many more years you're expected to live once you turn 65. And we're going to have another question using that table, so it'll come back up. And there are quite a few of them in your book also that are pretty cool to look at. So the OECD average heart disease rate per 100,000 is 112. So that's on average in these countries. There are 112 heart disease patients per 100,000 people in the population. The OECD average rate for dementia prevalence is 14.8 per 1,000 cases, or for 1,000 patients or people. Probably better to say people. Mexico had the lowest dementia prevalence of 7.2, and Japan has the highest of 23.3. And this one's related to their longer life expectancy rates. And then you can get into the difference between life expectancy and extended life and extended health. So ideally, yes, we would like to live longer, but we'd like to live longer healthier, not longer sicker. Okay, so that is also important to consider when we look at all this. So the life expectancy by gender and age, at age 65. So 83.1 years is average for women. Average life expectancy is 77.9 years for men, so women live longer than men. In the U.S. man, though, it's 76.3 years instead of 77.9. So it's kind of close, but still about a year or so off, or almost 2 years, like a year and a half off. The U.S. women is 81.2 years. So again, it's close to the OECD average, but it's still below it. And the OECD average of years of life at 65 is 19.5 years. So again, that would add up to life expectancy of like around 83.5, 84.5, something like that, 84.5 if you do the math. So the US is similar to the OECD average of 19.3, so it's pretty close. So we're only 0.2 difference there. And France, Japan, and Spain exceed the average. Okay, so again, here's our little chart. So I just decided instead of to do it at 65, let's do it at 100. So if you look, click here, and 65 is here, but if you look at 100, how many more years are you expected to live? And look here according to race and gender and all that. So who has the longest life expectancy at age 100? So there you go. And I put females, females, females because we've already discovered that females have a longer life expectancy than males. So it's going to be a competition between the females. Who lives the longest? All right, so let's look at infant mortality rates. So infant mortality rates are calculated as a comparison measure of country health status. So how well do we take care of our newborns and also of our pregnant mamas, because that plays into it also. So the infant mortality is the number of deaths per 100 live births occurring among the population of a certain area during the same calendar year. So the average OECD infant mortality is 3.9. So there's 3.9 deaths per 1,000 live births. The US rate is 5.8. So again, we're above the average. And this one is not a good thing to be above the average. And we'd like to be below the average. And it varies by state. But for example, in Mississippi, it's 9.3. But in New Hampshire, it's 4.2, which is a lot closer to the OECD average. And some of that has to probably a lot to do with educational levels in the states. If we have the most expensive healthcare again, why aren't we the best and have the lowest infant mortality? Okay, so what do you think the leading cause of infant mortality is? So before you look at the chart, I want you to just like in your mind try to guess it, and then click here and look at the chart and answer what is the leading cause of infant mortality. All right, so this is a video I think it's worth watching. It's only about 5-6 minutes on infant mortality, so you can watch it. And tobacco, alcohol, and obesity rates, other measures. So the OECD average percentage of population who smokes daily is 18.4%. And we have one of the lowest tobacco smoking rates of the OECD countries. Ours is only 11.4. So yay, we're good for the tobacco part. The OECD average use of alcohol is 2.4 gallons per consumer in 1 year. We are close to this average, so we're average for alcohol consumption. But for obesity, as you'll see, we're definitely probably the leading one, not in a good way. So obesity is classified as an individual with a body mass index greater than 30. The average OECD rate is 19.4% of the population, so right under 20% of the population. So obesity rates have increased the most in most OECD countries. It has to do with the westernization of our diet and of the world. So basically everybody copying what the US is doing, in this case is not a good thing. We have the highest obesity rates at 38.2%, so almost doubled that of the average of the OECD countries. Japan rate is the lowest at 3.7. And why that matters is because obesity is a risk factor for heart disease, diabetes, and cancer, and all three of those cost billions of dollars in the healthcare system. If we could just lower the cost for those, our healthcare system would be as expensive also. So it is really a global public health issue. So you can click on this and explore the statistics for Arkansas for adult obesity. And consider the effect of the cigarette tax that has had. So our smoking, we're the best for tobacco. Well, one of the best. We have the lowest at 11%. Do you think, for example, we should impose a soda or junk food tax? So this is, what do you think? Give me an answer, yes or no, and I'll share the answers later. All right. Health expenditures per capita and access to clinicians. So your OECD average health expenditure per capita, per capita means per head, capita is head, so it's per person. I'm going to have to answer that. Okay, sorry for the interruption. That was an important call I need to take. So the OECD average, so per capita expenditure is $3,500. So that is how much on average countries spend per person in healthcare, on healthcare. Okay, the U.S. spends triple that, nearly $10,000, so $9,892 per person. Switzerland, who has one of the best healthcare systems, does pay quite a bit, so they spend nearly $8,000, still less than we do. Luxembourg, it's a tiny country, they spend $7,600. So it gives you some ideas. Some of the countries that don't have healthcare coverage, they spend very little, and so that's also not something you want. You want to spend some, but not too much. Okay, so if your health expenditure per capita is like $5, we have a problem also. All right, practicing doctors per 1,000. So for every 1,000 person in the population, this should be, on average, there's 3.4 physician for the OECD. US rate is 2.6, and it does vary by geography. So as you can probably imagine, we have a lot more doctors here in the cities and stuff. So like Jonesboro has, you know, a lot of doctors and more population too, but we have a lot of doctors. But if you go out into the rural areas, you're going to see a much lower rate. So it does really much vary by where you live. The nurses per 1,000, the OECD average is 9, the US rate is 11.3, so we have plenty of nurses, we just don't have enough doctors. So, and yet, why do we track this? Why is this important? The more access you have to clinicians, the better health of the population. Sorry. So, in conclusion, many U.S. healthcare statistics rank lower than those of their countries that spend less on their healthcare system. And we're talking about, you know, the life expectancy and stuff like that. The things that we want to be higher are lower, and some of the things that we want to be lower are higher. And so this points to the fact that other countries' healthcare systems are more effective than the U.S. system. They provide universal coverage, which we do not, or that the citizens have healthier lifestyles, although obesity rates are increasing globally. And lastly, if you have any questions, you can put it there. So do the quick video. Just let me know if I'm going to help you in any way. You have a good afternoon.